Excuse me. Good afternoon, and welcome to Data Migration Strategies to Enable Successful Application Transitions, a Health System CIO Media Inc. production sponsored by Galen Healthcare Solutions. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of Health System CIO, and I will be your moderator today. We've got some interactive features today, namely the Q&A. So send your questions in as they occur to you, and we will take them later in the program. Questions or comments. So definitely send them in. If you want to download the deck, you can use the URL on your screen, and it has been sent out in the chat box. Just so you see how we are going to spend our time today, first we're going to go about 35 minutes with our main panel discussion featuring Chris Giroux, Manager, Informatics, Data Management and Integration Services with Northwestern Medical Center, and August Bory, Principal Technical Consultant with Galen Healthcare Solutions. We anticipate also being joined by Michael Archuleta, CIO at Bridge Care Health Network, Mount St. Raphael. He's running a little bit late, but hopefully he will be able to join us shortly. And then we will have our Q&A. So without further delay, I'm going to jump right into the good stuff. Chris, let's start with you. Can you give us an overview of your organization and your role?
Sure. My name is Chris Giroux. I'm the manager of Data Management Integration Services in our Informatics division in the IT department. I work for Northwestern Medical Center, which is a small community hospital in St. Albans, Vermont. When we kind of started this project of migrating data, we were taking data from one EMR to the other to get us all under one vendor, one umbrella, and that was moving 19 practices to our main acute EMR. So that's a little bit about me.
Very good, Chris. Thank you very much. August?
Sure. My name is August Bory. I'm a Principal Technical Consultant at Galen Healthcare Solutions. A little bit about Galen. We're a class-leading technical and professional services organization that really focuses and specializes in helping organizations in the transition services space. So moving from one platform or system to another, migrating the data for that system, helping implement the new system, as well as archiving the data from those old systems.
All right, very good. Next question. Chris, let's start with you. Approximately how many years of clinical data is it appropriate to migrate as part of an EMR transition?
That's a great question. That's one that we certainly had when we decided to convert our practices to our acute EMR. It's really on who you talk to. When we kind of started the project and we put that forth to our clinicians, the question back to us was, can we just bring it all over? So, as far as like clinically relevant information, I'd have to leave that question to the clinicians, but we were presented with, can't we just bring it all over? And so that's what we set out and attempted to do, was to bring over all of the information. Now, our prior EMR had roughly about 8 to 10 years of ambulatory or physician practice data, so we did just that. So we brought over about 8 to 10 years.
Let me ask you a follow-up question. So you said, well, it's up to the clinicians. So you're doing the transition. You say, well, what do you want? And they say, well, and I'm joking. Well, we're real busy. I don't know. Give me everything. Yeah. Now, does that mean that's the right answer? Because we'll probably touch on the issues of what you have, you're responsible for. And so there's certain liabilities there, and there's limitations of what, there's requirements for how long you have to have something. But beyond that, it's a question of should you have it. So more thoughts there, Chris.
Yeah, I mean, we had a lot of those same sort of questions from a medical record standpoint, like what was the requirement to keep. We had one of our clinics is a pediatric clinic, so actually for Vermont, we were required to keep a longer amount of data. So really, the fact that we had about 8 to 10 years in our existing EMR that we wanted to migrate, that seemed about appropriate. But I think it's a good question to ask and really challenge the folks that are, just kind of saying, we just want it all, because sometimes there are challenges that you have to work through, meaning, do I have enough storage? Is this going to, have an impact to performance long term? Those sort of things. With 8 to 10 years, we didn't have as much of a concern about it, but certainly those are things that you really have to include your medical record departments as well as clinicians in making that decision.
Very good. August, thoughts?
Yeah, it's funny you said we want it all. That's in helping organizations kind of decide and make recommendations about what to migrate. That's probably the number one thing that we hear, especially at the outset, is, oh, well, we want to bring everything. We sometimes just caution against that, like for some of the reasons you said, Chris, storage, or another big one is, using a new system, bringing a lot of data, maybe bringing too much data. It can sometimes be difficult to find the data that they're then looking for once they get live on that new system. So it does depend a little bit on kind of the scope of what's being brought over. But the sweet spot that we kind of usually typically land in with organizations is somewhere in the 3 to 5 year range. Depending on how long they've been live on the system, that can be a healthy amount of data. It can be a lot of data if it's an organization that's been live for a while, has a lot of patience. But that's typically kind of where we end up with 3 to 5 years. One of the questions that we ask very early on is what information is going to be needed by the providers to provide continuity of care for the patients on that new system. So the first time the patient comes in, what information is really needed that needs to be at the provider's fingertips, and that's kind of the direction that we start that conversation in.
Yeah, and
go ahead, Chris.
If I could add to that, and it's really, you have to query not just 1 or 2 clinicians, I would say in our case, we had 19 practices. And so all of those practices in general somewhat might practice a little differently or have different thoughts around it, right? So the pediatric, clinicians had other thoughts around it, and they were really dialed into needing immunizations, for example, whereas not to say that primary care and other, practices weren't concerned about it, but it wasn't as important to them, right? Because they might not be as dialed into that. So it's really kind of getting a laundry list of what is most important. To your point, August, is deciding what are the most important points for them to practice and see a patient on day 1.
Yeah, and to add one more thing onto that too is, like you said, it can be different depending on what data is being brought over. One of the things that we see commonly, especially for a pediatric population, like you mentioned, we might bring over or recommend bringing over all history of vital signs, for example, so that in the new system, those growth charts can be looked at and trended. That may differ depending on some of the other data that's being brought over.
So, August, do you think it's better for healthcare IT executives and CIOs to approach clinicians with a suggested plan as opposed to saying, "What do you want?" Because you're going to get that, "Give me everything." Because "give me everything" allows them to move on to the next thing. They're done. They answered 3 words and they're done. So it's much more complicated to pare things down than to take it all. So what's the best approach for IT executives when dealing with, the clinical heads?
Yeah, that's a good question. I'd say starting with a recommended approach somewhere in that kind of range, like I was mentioning. Obviously executives and a CIO is going to have other things to think about, cost and kind of feasibility and technical approaches to the project, whereas the clinicians might, like you said, just say, well, we want it all. So I would definitely recommend kind of going in with an approach and maybe talking to peers in the community and other groups that have gone through a similar process, and kind of see, here's what we think we can do, here's what we've seen work well, because if you leave it open, then
Right.
then they're going to want everything, and that gets costly.
Very good. All right. Next question. What types of discrete data are appropriate to migrate as part of the transition? August, let's stick with you first.
Sure. So kind of the main ones that we see right off the bat, we're going to want to migrate the patient information, patient demographics, as well as some of that patient level information, like the problems, medications, allergies, immunizations, like Chris mentioned. Those are really kind of a no-brainer, in my opinion, and that's really kind of the baseline of where we start when we are talking to an organization about bringing data over. Another one that's really big are trendable results, lab results, pathology, point of care tests, things like that, as well as some radiology and imaging results. Those kind of make up the core of the discrete data. You'll also, another common one are the provider notes or clinicians' notes, progress notes, things like that. Oftentimes, the last few notes for a patient are highly desirable, so getting that information into the new system is usually a pretty important piece of it. Some of the other information works really well with either limiting the number of years of the amount that's brought over, or referencing it in an archive type solution. So that's kind of the trade-off that we see, is what's the discrete information that's going to be able to be brought over efficiently, and also is going to light up that new system, right at the provider's fingertips so they can use it. And then what is more easily accessible in an archive type solution, where they can, if they need to go back and look at something, it's right there, but it might not actually physically live in the new system.
Chris?
Yeah, I would echo a lot of what August referenced: the medications, the allergies, the problems, the immunizations, vitals, family history, past medical history. Those are the key discrete data elements that our clinicians were looking for. And a lot of the vitals can, mean, height, weight, and blood pressure and all those sort of things, but there are other elements too, some particular, smoking questions, all those sort of things that are really key to kind of treating the patient are definitely, I would think, most any organization would look for in discrete data. In addition, and I think August referenced this, is also some of the documentation, which is discrete, but it kind of comes over more as a report that folks are looking for too. So like a document conversion of some sort. Unless you have an eloquent way of accessing those easily, a lot of clinicians are referencing previous documentation or notes, and they need that at their fingertips too. So unless you have a way to access those quickly and easily, I know our organization required or wanted a document conversion, so we also did that in addition, which is a little different than the discrete, but it is the data that they're truly looking for to reference to treat the patient in front of them.
Very good.
And then I'll just
go ahead.
A couple other things that came to mind that are kind of smaller, but we've seen organizations find a lot of value in bringing over things like a patient's primary care provider, or maybe their preferred pharmacy that they use for prescriptions. While those aren't huge pieces of data, they would probably get rekeyed in anyway in the new system, and can just help for, it's a pretty small lift in getting that information sometimes over to the new system. So just kind of there's other ancillary discrete pieces of information that can come over as well.
Yeah, and that's a good point too, the demographics, the visits with, maybe some insurance information for reference. That definitely, we benefited from that as well. because otherwise it would be someone either manually keying that in or, having to go dig for that information. And so those were, helpful pieces more on the administrative side, but it definitely eliminated several steps after the go live of the converted data.
All right, excellent. Next question. Chris, let's stick with you. What are the drivers for discrete data migration as part of the transition?
Yeah, I would say the key drivers is to eliminate any manual, keying of information, because we all know folks make mistakes or, might be putting it in the wrong place, that sort of thing. And so a systematic approach was something that we felt was a much better way of handling this for quality assurance of the data. Whenever you're, you have to come up with a resource to potentially key this information, but it's also the potential of errors or incorrect information coming over if you're asking someone to manually do it. So we were really searching for a systematic way that we could just drive that data and feed it into the new system to eliminate that cost for resources to key it in and eliminate the potential for errors. So those were kind of the big things, knowing that this is, very important clinical information that really needs to be accurate.
August?
Sure. So yeah, I mean, definitely what everything that Chris mentioned, and one of the kind of key pieces I think I mentioned earlier, but the data will light up kind of that new system in all of the places that providers are kind of like, if they're getting trained and they're kind of preparing to move over to use a new system, the discrete data migration will help data land and show up in all those places where they're going to be used to seeing it moving forward. So it can be a really good training tool as well, a way to kind of improve their satisfaction as they're using a brand new system and kind of getting acclimated to that. Can help keep productivity levels, higher, so there's not as much manual reentry of the data once they're live on the new system. And then another one is kind of, since that data is discrete, from a reporting perspective, whether the organization is reporting out from that new system or whether there's just internal reporting initiatives, that since that data is discrete in the database, you can access it, you can pull it and report on it as you would just any other data that was living there.
Yeah, thank you for saying that, because that is another key element. Is the other thing that was really important is a lot of this discrete data we needed to be able to turn around and pull at some point for reporting, whether it's PCMH or meaningful use or promoting interoperability, so that those things needed to be there. And again, you don't want to have to manually enter all of this data. So there are other, other than the upfront having the data there, but it's also on the back end of being able to pull it out and extract it later on as well. So yeah, that's a good point.
All right, excellent. Next question. What strategies exist for differentiating migrated data from existing data, if that's applicable? Chris?
Yeah, so our EMR actually enabled us to do that pretty fairly easily. We were able to see the source or understand the source. And I'll use the example of like medications and allergies and, those sort of things. Those existed as external data, I will say, so that when the patient presented, they could see that information. They could see that the source was external or came over from another system, and then they could reconcile that data right in front of the patient. So that was really key. So it kind of enabled them to see what data we had collected in our existing system, and then what data was collected in our other system that we brought over, and then it gave them the opportunity to reconcile that. And again, that was our EMR, but it was very helpful so that they could understand that, oh, this is this was essentially they could tell what was the converted data. A lot of times, especially with the discrete data elements, they were able to do that. Not 100%, but the key discrete data like meds, allergies, immunizations, vitals, you know, those elements, they could see exactly where it came from. And that's really good, so they could kind of make sure that they had a complete and accurate record. They could see it all there and say, oh, okay, I get this. This is coming from my other system. This is what I have here. Let me kind of compile this, bring this all together, run it by the patient, and make sure it's accurate.
Very good. August?
Yeah, and Christy brought up kind of exactly the first thing I was going to mention there as well. When there's kind of that reconciliation or, you know, sort of landing spot for some of that discrete information. And from our experience, a lot of the big EMR vendors kind of have that functionality. And so it does really make it easy to say, oh, this medication came from this outside source. Here it is compared to all the meds that are currently on the patient's chart. And I think that's a really helpful tool for clinicians to be able to see that information and the different places it came from. And a lot of times it might even say, you know, blah, blah, blah conversion. So that's you're able to see exactly that it's converted data from this specific organization. Another one that we see commonly is, especially for information that's being tied to an encounter in that new system, that encounter might be referenced as a conversion encounter. So any lab results or maybe any progress notes, anything that we have converted to that new system and tied to that encounter, a user can easily say, oh, all this data is tied to this conversion encounter. It's converted data. You know, now I know that that's where it came from. It really is going to look and feel just as in any other data would. And that's kind of one of the goals of the migration as well, is we really want the data that we're migrating to look and feel largely just like any other data that the user is seeing, but with those kind of different ways that they can differentiate that the data was migrated.
Yeah, if anything, it just helps to tell the story a little more and understanding of the entire patient record. I know our HIM team really took a close look at how our documents were built and, you know, how they were going to match up what was coming over from our other system to what was existing in our medical record, and it was important sometimes to be able to notate that this was a converted document, right, so that people could clearly see that and find it easily. And in some cases, it was more important that it just seamlessly was there, like it had always been there. So it kind of depends on what you're looking for, but you definitely have to kind of do that deep dive and analysis of what would work best for, you know, what element.
Very good, very good. All right, next question. August, let's start with you. What is the ROI, a question everybody likes, from data migration? How is it measured and justified?
Yeah, so, you know, just working with organizations that have performed migrations, you know, many migrations, and then also kind of interacting with organizations that have not, you know, anytime that that organization decides to do that migration, you know, I really think that there's all the benefits like that we've been talking about in terms of kind of the productivity that I was mentioning earlier, being able to go live on that new system and, you know, not have a huge or at all a decrease in the amount of patients that can be seen. You know, all that information is right there, kind of at the provider's able to view it and use it. You know, everything we've heard from clients that have not done a data migration, you know, to be honest, I'm not sure how they did that. It must have been a huge undertaking in order to kind of help that data, whether it's being abstracted manually or whether they're just kind of leaving it in the old system and letting the users reference it for, you know, an extended period of time. You know, I think we really see a ton of value in bringing the data over, especially when you're talking, you know, about a large number of patients. Anytime there's a system that maybe is one provider, two providers, that's kind of where you get into the kind of the frame of, well, maybe it's not worth pursuing an electronic conversion. Maybe some of that data can be abstracted because there's not a huge number of patients. But anytime we're talking about a large number of patients, I think there's really a ton of value in getting that data over discretely.
Chris?
Yeah, I would agree with that because again, you're either going to have to pay a group of people, because it can be more than typically a person, to key that information, and then depending around the amount of data that you have, will kind of determine that lift or that effort. And if you're wanting to, pull in several years of data, your volumes are probably quite high, and to, pay someone manually or, whatever to get that data in there, it just, for us anyway, it did not make economic sense, as well as we were also really concerned about errors in that manual keying of data. So to us, that seemed like it offset maybe the cost of doing a conversion. It outweighed the potential keying errors, so leading to inaccurate data and reporting and those sort of things, versus paying someone to manually enter all of this data, and how much time it would take to really do that and to be able to get it done in a timely manner for our go live. We had about 10 months from the time we started our implementation to when we went live, and how much can one truly input in a timely manner where it was up to date, right? Because you can't have them keying this information 6 months in advance, right? They have to key it in advance maybe of a couple weeks, right? Because you want it to be up to date and accurate. So it just didn't make economic sense to manually do that. So I think it really is based on how much data you have and how many resources you have to potentially do something like that. And I think every organization might be a little different, but if you have a significant amount of data, then I'm not sure how you could justify paying someone to manually key it versus having it converted.
August, I saw you nodding your head in agreement.
Yeah, you brought up a good point, Chris, in terms of kind of the fidelity of that data, because, right, if you migrate it discretely and you migrate it or have it abstracted, theoretically the data will be in there either way. When we do or perform our migration, the data validation and the patient validation is really the majority of the project timeline. And so there's kind of multiple rounds of that validation where it's loaded into a kind of a staging environment. It's looked at by Galen as one party, but also by the clinicians, by the end users, by the real people whose data it is and who are going to be using it, day in and day out. And that happens multiple times and over multiple iterations. So that's really a key piece of the project, is ensuring that the data that is brought over discretely, because there is so much of it, that it's going to land and be accurate in that new system.
And the other thing I just wanted to add was, the other thought is, we are, paying, vendor support on our previous system, and at some point we want to not have to do that, right? So if you are exporting, the bulk of your data, maybe you still need to archive some of it, but if you're extracting and pulling out that data and it's now in your new system, the thought also was that you could discontinue the annual or the monthly fees that you're paying to your existing vendor too, which was also part of our plan, is within a year that we'd be able to turn off our prior EMR, so that, because all of the data we had moved over, and we could, essentially save, money on a second system, maintaining and, paying our service contracts on it. So that was definitely another, piece is to save that money as well.
All right, very good. Chris, let's stick with you. Have you engaged risk management to help assess potential legal risk of not pursuing data migration?
We had our risk group very much involved in our, decision making throughout this. They were at all of our steering committees, so they were definitely in the know of, what would happen if we didn't have it, or if we did, and how we're managing it. So we definitely consulted with them, and what might be the pros and cons of either, so to speak, so that they could weigh in on their decision making. And it was definitely a concern of, again, manually keying is a significant risk. So, that definitely outweighed, I think, the risk of a conversion, knowing that, to August's point, like, we did so much, like the bulk of our effort was in the validation to make sure that the data did come over, that it came over correctly. And that was where we put our time and effort to make sure that the data was 100% accurate that came over, versus, again, potentially paying someone to manually key that in when, there's just not nearly as many controls, if you will, around that. So we definitely did loop in our medical records group and our risk when making those decisions.
August, thoughts?
Yeah, I'll say, by and large, when we get engaged, an organization has mostly made the decision to perform a data migration, and so that's kind of where we get brought in. The times when we kind of can help assist with figuring out the best route for a given system. There are when there's kind of some of those smaller systems that maybe don't make economical sense to migrate that data over. We would probably recommend, or would recommend, kind of an archival strategy, like Chris was alluding to, being able to turn off those systems and not have to pay licensing costs and server costs and storage costs. So from an archival perspective, you're getting kind of archiving all of the data from that system. So from a legal perspective, you can turn that old system off. So those are the types of conversations that we would typically have. I'd say the majority of the time, the migration and archival are really a complementary set of services, where a portion of the data is migrated for maybe a larger electronic system, and then the entire data set is archived.
All right, very good. Next question, Chris, let's go with you. How do you ensure all data is loaded prior to go live?
I think August and I kind of alluded to this a little bit, is there is significant amount of work put into preparing a data file, and significant amount of testing. So we probably did, I want to say 6 or 8 test file loads. So we gather, a group of records. There'd be a process of several folks, not just 1 or 2 people, that would access those records and take a look and compare them to our existing live to make sure that the data is accurate, and they would bring back to us if we were missing components or whatever might not have come over correctly, and then we would make the changes, make the fixes, and then kind of recompile, if you will, another data set and reload again. And then we would test, we would say about 10% of the records, and it would be a spot check of, making sure that we are looking at all different patient types, for example, or different, from different locations, different practices, to make sure we had a really good sampling across the board, to make sure that, we were looking at everything. And that took folks from our medical records department, that took some RNs, some like clinical folks, that took some staff from our information technology group, our informatics group. So we had several, so I would say several eyes on it, lots of testing, lots of validation. That is worthwhile time. And, it's amazing. We were able to tweak and fix a lot of things. We found things that were like not good data in our previous system. We were able to filter out so that we chose not to bring it over. It's just really extensive testing and validation by a large group of people. And when I say large, what I mean is like a good different groups of folks looking at it from different perspectives. So again, HIM, IT, clinicians, because we all look at things a little differently and comparing them to our existing live. And then just running, providing that feedback, working with your vendor very closely and retesting and revalidating. We did that several times. We worked through lots of issues, and to date, we have not found any significant problems with our migration. But again, that was where to focus your resources, in my opinion.
August?
Yeah, and I'm glad to hear you say that you haven't found any significant issues as part of the migration. just from a group that does those types of projects, I'm just happy to hear that. Exactly like what Chris mentioned, the multiple iterations of validation. Part of the project and the validation component of the project that we will help out with is, we call it full-scale validation. And the reason for that for performing that component of validation is really to get an idea of how that data is going to load and timing and everything once you go to load it into the system, into the production environment. So those multiple rounds of validation, that full scale where all of the data is loaded into a test environment, in our experience, is kind of the last test run, if you will. It's kind of a dry run for the production load. Chris mentioned, I think, around a 10-month project for the migration that she went through. That's kind of right in where we see it as well, anywhere between 7 to 10 months, depending on the scope of the project. And the majority of that is that validation. And then that last kind of load into the test environment of the full set of data really gives you an idea of how that data, how long it's going to take to load into the production environment for that go live. And so oftentimes that could be 2-3 weeks, something in there, depending on how much data there is. And so getting a real idea of how long it's going to take allows you to kind of plan out that whole go live event and to start, this many weeks before, load the majority of the data, and then we'll perform catch-up loads or gap loads as we get closer to go live to make sure that once the users go live on that new system, they have the most up-to-date information as possible. So it's really kind of working through that entire validation process, make sure that one, you're resolving any issues, and two, that when you go live, the data is as caught up and as current as possible. And then we'll also, after the fact, because from what we've seen, as much as organizations would love to be able to kind of cut off a system the day of go live, there's always going to be kind of cleanup things and practices and processes that are happening in that old system. And so we'll go back 30 days later, 30 days later, and do a catch-up load so that really we're capturing all of the data that was entered, not just before go live, but in the kind of trickling in after go live as well.
All right, very good. We have a question that has come in through YouTube. We're live streaming to YouTube today. Question has come in for Chris. How long did it take to get your data in your new EHR?
Well, we started working on the data migration about 10 months prior to go live. But as far as like loading the data, we started that 2 weeks prior to our go live, and August kind of, I think, alluded to it a little bit, is you kind of load up to a certain point, like up to the previous month, and then that takes about 2 weeks to load, and then, give or take. And then there's, right before you go live, there was kind of like a catch-up file that kind of gave the last bit of information. So, I won't say it was 2 solid weeks, but we kind of booked it out. It was 2 weeks prior to go live that we started loading the data. I hope that answers your question.
Very good. Yes, I think that is good. I think we touched on this, so let's move on. Should the entire patient population be migrated or a subset based on last visit date or other filters? August, let's start with you.
Yeah, I mean, we almost always see a subset of data being migrated, just for kind of some of the reasons that we talked about earlier in terms of, not wanting all of the data, or sometimes when you migrate all of the data, it can be a little cumbersome to find in that new system. And also just, only bring over kind of what is needed to provide that continuity of care. A lot of times it is based on that last visit date. So we might say any patient who's been seen in the last 3 years, we'll bring over their data and we'll bring over the last X number of years. That kind of last time the patient was seen, a lot of times we'll ask the question of the organization, well, how does your organization define an active patient? And sometimes it is the patients that have been seen in the last 3 years. And if they haven't been seen in the last 2 years, when they come in on that new system, they're effectively a brand new patient. And so sometimes that's the kind of criteria that's used to inform and determine the data that's being brought over as part of the migration. In other cases, sometimes it's just saying, we want to bring over the last 2 years of data. And it just goes back from a specific cutoff date. Anything before that is expected to be found either in an archive or the legacy system. If it's more recent than that, then it should be in the new system. Where we've seen organizations kind of want to pick and choose about how many years of different data is brought over. Let's say it's full history of vitals, 3 years of lab results, 5 years of notes. I'm just throwing dates out there. That can be a little confusing for the end user and the clinicians when they're seeing data in that new system, because it can be hard to remember, okay, well, if it's this data, it's 3 years. If it's this data, it's 5 years. And it can be hard to determine if the data that should be in there actually is in there. So we try to recommend, to keep a general time frame in terms of how much data is brought over, so that it's easy for everyone to understand that and know when something is in there or is not in there and whether it should be.
Very good. Chris, thoughts there?
Yeah, I mean, it's again kind of what your organization is looking for. And the key is really to get the information, the necessary information to treat the patient in front of the provider and clinicians as easy as possible. And sometimes that might be a little bit of a hybrid situation, and it all depends on your EMR and how quickly and how easily you can access that historical data, or if it makes sense to just bring it over and just have it there so that you can discontinue, your service with that previous vendor. So I think it's almost a case by case, if you will, of what your organization is looking for. Again, we're a small community hospital where a lot of our patients came to our hospital for labs and DIs, and so we already had a lot of information on our patients already. So we're really just looking to bring in those physician practices information over. So now in our EMR, we have a very good, complete record of our patients because we have both sides now. So it's really kind of what you're looking for, what your goals are.
And you brought up a great point.
Go ahead, August.
About in an organization where patients are kind of seen in the hospital, but then they're on a different system in the ambulatory setting. A lot of times, kind of the breakdown of organizations that we see, some data already might exist in the inpatient system. And so we'll be kind of tasked with determining, well, what data should be brought over from an ambulatory perspective. We don't want to duplicate any data that already exists in that inpatient setting, that inpatient system. So like you mentioned, it is kind of an organization case-by-case basis, but we do see that a lot of times trying to prevent duplicates, filter out information that may have been interfaced, such as lab results, in those ambulatory systems, because they already exist in that inpatient system, and there's no, we want to avoid any duplication of data if we can help it.
Yeah, I strongly recommend like a really big, I'll say, spreadsheet or some sort of cross-reference of all of the data that you're looking for, and kind of mapping out a plan, if you will, of what do you need discreetly and how far back. I mean, I think you have to go through the whole exercise, and that planning will set you up to work with a vendor. I mean, it's time well spent planning that all out in detail.
I want to sneak in one more audience question. We're running short on time. And you had mentioned previous vendor in your answer, Chris, working with the previous vendor. What involvement, if any, was required from the legacy EMR vendor and the go-forward EMR vendor? So what's their role? And August, when it's your turn, do you play a role as the service provider in dealing with those vendors, or to what degree does the customer, Chris, have to be involved? You get a lot of chefs in the kitchen. So go ahead, Chris. Why don't you go first?
That's a fantastic question. So it's really, you have to really work with your, I'll say, previous vendor, or maybe your current vendor, on what they can produce for you. So our previous vendor was able to create an XML file, or essentially a CCD, that we could extrapolate this data from, and then we worked with another vendor to kind of say, okay, now we have this in this form, how can we translate this to the receiving or our new EMR specifications? And so you have to really have some technical folks involved that can understand some of that language, if you will, and understand how data might be transformed along the way, so that you can help, kind of get it from point A to point B. And we were able to work with Galen in particular to kind of map that out, because, we went to our prior vendor. They basically just said, this is what we can do. And then we had to figure out, okay, so how do we get it from that point to the point of our receiving EMR? And so we needed some help technically along the way to kind of figure that out. And so some of that was technically in-house in our IT group, and some of it was not. And that's where we needed to partner with consulting services to kind of help us out. But those are important questions to ask, because there could be some additional costs or fees that you just want to kind of plan for.
August, do you want to touch on that, and then consider that giving you the last word for today, then we're going to wrap?
Yeah, definitely. When an organization kind of comes to us looking for assistance with migrating data, kind of our preferred approach is really to kind of handle it from start to finish. We like to get into the kind of the database, or the nuts and bolts of that existing or current system, legacy system, however you want to phrase it, and really get that data out. Anytime, and it does happen that the legacy vendor is involved. I'm sure, Chris, you can attest to this, working with the legacy vendor. It can slow things down, create additional costs, like you mentioned. Sometimes there's no way around it. Certainly, the best approach that we've seen is to kind of really get in there and access that legacy system itself directly, get the data out, and then get it into with whatever the format that it needs to be in order to get it into that new system. And like Chris mentioned, every new system, every target EMR is going to have a little bit different format that it needs to be in. And so that's really kind of one of the things that we help out with, both from a technical and kind of overall feasibility perspective, is making sure that data gets out of that old system as quickly and as easily as possible, and then into the format, whether it's XML or whatever, HL7, that it needs to be in to go into that new system. And really engaging the target system vendor to kind of help if they're needed from that perspective, but hopefully as little engagement from the legacy vendor as possible.
All right. Well, that's about all we had time for today. Great conversation. Really a lot of great detail, deep detail for our listeners. Regarding continuing education, you could use the final slide in this deck for your CEU needs. You'll receive an email when the on-demand recording of this event has been posted. If you'd like to sponsor one of our upcoming events or book a custom event, you can reach out to Nancy Wilcox from our team, and you can go to our website to register for our upcoming webinars. So with that, I want to thank our panel, Chris Giroux, August Borey, and Michael Archuleta for trying to get here. He had some travel difficulties, so unfortunately we missed Michael, but we wish him very well in his travels. And I want to thank our sponsor very much, Galen Healthcare Solutions, for making the event possible. And I want to thank you, our attendees, for continuing to join us. And with that, everybody have a wonderful day. Thank you.